Welcome back to Bugs and Beyond, your one-stop shop for everything infectious diseases. Today we're diving deep into the world of fluoroquinolones. You know, those antibiotics that seem to be everywhere, but they also have a bit of a reputation.
That's right. They're incredibly effective against a wide range of bacterial infections. But they've also been linked to some serious side effects, which has sparked a lot of debate in the medical community.
Okay, so before we get into all that, let's start with the basics. Where did these fluoroquinolones even come from? I'm picturing scientists in lab coats huddled over bubbling beakers, maybe having a eureka moment.
Well, it wasn't quite that dramatic, but the origin story of fluoroquinolones does involve a bit of a happy accident. Back in the 1960s, researchers were trying to synthesize chloroquine, an anti-malarial drug, when they stumbled upon a byproduct called nalidixic acid.
Nalidixic acid.
Yeah.
That rings a bell. Isn't that still used for urinary tract infections? UTIs.
Exactly. It turned out to be remarkably effective for UTIs because it concentrates in the urine. However, nalidixic acid, which was the first quinolone, had its limitations. Its absorption in other parts of the body was poor. And it wasn't effective against certain types of bacteria, like the infamous Pseudomonas.
So it was a promising start. But scientists knew they could do better. And that's where the clever molecular tweaking comes in, right?
Precisely. They realized that by making subtle modifications to that basic quinolone structure, they could create even more powerful drugs. And that's how fluoroquinolones were born.
And it's amazing how a tiny tweak to a molecule can have such a huge impact on how it works in the body. For instance, I remember reading that adding a fluorine atom to a specific spot on the quinolone structure increased its ability to inhibit bacterial DNA gyrase by tenfold. Can you remind us why that's such a big deal?
Absolutely. DNA gyrase is a crucial enzyme. That bacteria need to replicate their DNA and divide. By inhibiting this enzyme, fluoroquinolones essentially stop bacteria in their tracks, preventing them from multiplying. Think of it like cutting the enemy's supply lines. Without the ability to replicate their DNA, the bacteria are doomed.
That's a pretty powerful weapon. But didn't I also read that fluoroquinolones can inhibit another enzyme called topoisomerase species?
You're right, they do, and that's important because different types of bacteria rely more heavily on either DNA gyrase or topoisomerase phi. Gram-negative bacteria tend to be more susceptible to drugs that target DNA gyrase, while gram-positive bacteria are more vulnerable to drugs that inhibit topoisomerase 4.
Okay, so that's why scientists have been playing around with different modifications to the fluoroquinolone structure. They're trying to fine-tune their attack depending on the type of bacteria they're targeting. What are some of the other key modifications they've made? And what effects have those had?
Well, one clever trick is adding a piperazine group to a specific position on the molecule. This makes the drug much more potent against gram-negative bacteria, like those pesky Pseudomonas that nalidixic acid couldn't touch.
So that's how they overcome that initial limitation. What about gram-positive bacteria? Have they found ways to improve activity against those?
Yes, they have. Adding a pyrrolidine group at the same position as the piperazine actually enhances activity against gram-positive bacteria. So you can see how these subtle changes allow scientists to tailor the drug's activity to target specific types of bacteria.
It's almost like they're choosing their weapons based on the enemy they're facing. Pretty impressive. But what about making these drugs last longer in the body so people don't have to take them as often?
That's where the methoxy group comes in. Adding this group at yet another specific position on the molecule not only enhances activity against gram-positive bacteria, but it also increases the drug's half-life.
Okay, so longer half-life means it stays in the body longer, and patients can take it less frequently. It's like getting a 2-for-1 deal. So we've got these souped-up fluoroquinolones designed to target specific bacteria and hang around in the body longer. But can you walk us through how they actually get to the site of infection and do their bacteria-busting work?
Sure. That's where pharmacokinetics comes in, the study of how drugs move through the body. The great thing about fluoroquinolones is that they have excellent distribution. They can penetrate various tissues, including the central nervous system, which makes them valuable for treating a wide range of infections, from pneumonia to UTIs.
That explains why they're so versatile. But how are they eventually eliminated by the body?
Most fluoroquinolones are primarily eliminated by the kidneys. However, there's one interesting exception, moxifloxacin. It's metabolized mainly by the liver, so it doesn't require dose adjustments for patients with kidney problems.
That's a handy fact to keep in mind. Before we move on, can we take a closer look at the specific fluoroquinolones mentioned in these articles? We've got ciprofloxacin, levofloxacin, moxifloxacin, and delafloxacin. What are their individual strengths and weaknesses? What sets them apart?
Let's start with ciprofloxacin, the veteran of the group. It's been around the longest and is renowned for its activity against many gram-negative bacteria, including those tough-to-treat Pseudomonas aeruginosa.
Ah, yes, Pseudomonas, the bacterial bad boy. What about levofloxacin? How does it stack up?
Levofloxacin is also a strong contender against many gram-negative bacteria, but it has improved activity against some gram-positives compared to ciprofloxacin. It's important to remember that both ciprofloxacin and levofloxacin need dose adjustments for patients with reduced kidney function, though.
Got it. And what about moxifloxacin, the one that's metabolized by the liver? What are its claims to fame?
Moxifloxacin is particularly known for its excellent activity against respiratory pathogens, including Streptococcus pneumonia, and those atypical bacteria like chlamydia and mycoplasma. It also covers some gram-negative bacteria, although not as broadly as ciprofloxacin.
So a good choice for respiratory infections,
Yee.
especially in patients with kidney issues. What about delafloxacin, the newest kid on the block?
Delafloxacin is interesting because it's specifically designed to combat some of the resistance mechanisms that bacteria have developed against older fluoroquinolones. It even shows activity against MRSA, a particularly resistant type of staph bacteria. And it covers a wide range of both gram-positive and gram-negative bacteria, including our friends Pseudomonas.
It sounds like delafloxacin is trying to tackle the growing problem of antibiotic resistance head-on. Speaking of resistance, how exactly do bacteria develop resistance to fluoroquinolones? It seems like they're always finding ways to outsmart us.
They are incredibly adaptable. One way they fight back is by altering those target sites we discussed earlier, DNA gyrase and topoisomerase the face, through mutations. They can slightly tweak the structure of these enzymes, making it harder for fluoroquinolones to bind and inhibit them.
So it's like they're changing the lock so our key no longer fits.
Precisely. But that's not their only trick. Bacteria can also develop efflux pumps, which act like tiny bouncers, pumping the drug out of their cells before it can do any damage.
So they're kicking the drug out before it can even get to work. Sneaky little buggers. What other defenses do they have?
They can also reduce the number of porin channels on their surface, making it harder for the drug to even enter in the first place. It's like building a fortress to keep the enemy out.
Wow. Bacteria are like tiny ninjas, always a step ahead. And to make matters worse, aren't there also enzymes that can directly inactivate fluoroquinolones?
Yes, there are fluoroquinolonium glycoside modifying enzymes emerging that further complicate things. This is why it's so crucial that we use antibiotics judiciously, only when they're truly necessary. Overprescribing and inappropriate use are major drivers of antibiotic resistance.
That makes sense. It's like we're in a constant arms race, and we need to be careful not to give the enemy the upper hand.
Exactly. We're battling not only the bacteria themselves, but also the looming threat of resistance, which could render these valuable drugs useless in the future.
So we've talked about all the amazing things fluoroquinolones can do, but I know they also have a bit of a dark side. Didn't the FDA issue several warnings about them?
Yes, and for good reason. While they're undoubtedly effective, fluoroquinolones aren't without risks. One of the most concerning is the risk of tendinitis, and even tendon rupture, particularly affecting the Achilles tendon. I'm sure you've heard those stories about athletes rupturing their Achilles after taking a fluoroquinolone.
Yes. It's a stark reminder that these side effects are very real and can have serious consequences. And I think you mentioned earlier that the FDA has also warned about the risk of aortic aneurysm and dissection, which sounds terrifying.
It is a serious concern, especially in patients who already have risk factors for these conditions. And the FDA warnings don't stop there. They've also highlighted the risk of peripheral neuropathy, which can cause debilitating pain, numbness, and tingling in the hands and feet due to nerve damage.
So these aren't just minor inconveniences. We're talking about potentially life-altering side effects. And what about the mental health side effects I've heard about, like anxiety, paranoia, and even hallucinations?
Those are definitely on the FDA's radar as well, although they seem to be relatively rare. But even one case is too many, right? And perhaps most concerning are the warnings about potentially permanent damage to tendons, muscles, joints, and the central nervous system.
Wow, that's a lot to take in. It seems like prescribing fluoroquinolones requires a careful balancing act, weighing the potential benefits against a whole host of potential risks.
You're absolutely right. It's not a decision to be taken lightly. And to complicate matters further, fluoroquinolones can also interact with a wide range of other medications, potentially leading to serious complications.
Okay, before we dive into that can of worms, I want to pause for a second and pose a question to our listeners. Imagine you have a patient with a severe infection that you know a fluoroquinolone could knock out, but they also have some of the risk factors we've just discussed. What are the key things you would consider before making that prescribing decision? Take a moment to think about that.
That's an excellent question to ponder. It really highlights the dilemma that clinicians often face when considering fluoroquinolones.
And it emphasizes the importance of thorough patient assessments, careful risk-benefit analyses, and open communication with our patients.
Okay.
Ready to unpack those drug interactions?
Let's do it. One important interaction to remember is with warfarin, a commonly used blood thinner. Fluoroquinolones can amplify the effects of warfarin, increasing the risk of bleeding, so close monitoring of blood clotting is essential in these cases.
And what about patients with diabetes who are taking medications to manage their blood sugar? Could fluoroquinolones throw a wrench into their glucose control?
They certainly can. Fluoroquinolones can exacerbate both high and low blood sugar, making it much harder to maintain stable blood sugar levels. So this is another red flag for doctors to watch out for.
Are there any other drug interactions we should be aware of?
Plenty. For instance, fluoroquinolones can interact with medications that prolong the QT interval, a measure of the heart's electrical recharging time. This can lead to a potentially fatal heart rhythm problem. It's called torsades de pointe.
Okay, that definitely sounds like something we want to avoid. So I'm guessing combining fluoroquinolones with QT prolonging drugs is a big no-no.
You got it.
Okay.
And it's also important to be cautious when prescribing them alongside NSAIDs, as this combination can increase the risk of seizures.
So it seems like fluoroquinolones have the potential to interact with a whole pharmacy's worth of medications. It really highlights the importance of thoroughly reviewing a patient's medication list before prescribing anything, especially a powerful drug like a fluoroquinolone.
You're absolutely right. It's a complex web of interactions, and it's crucial to be aware of the potential pitfalls. This is where pharmacists play a vital role in ensuring medication safety. They're experts in drug interactions and can help doctors choose the safest and most effective treatment options for their patients.
Speaking of choosing the right treatment, I think it would be helpful to go through some real-world case studies to see how all this information comes together in clinical practice. What do you think?
I agree. Let's put our knowledge to the test and see how we would approach these often challenging scenarios.
All right, case number 1. We have a 70-year-old man with a history of hypertension, type 2 diabetes, and an abdominal aortic aneurysm. He's admitted to the hospital with shortness of breath and is diagnosed with community-acquired pneumonia. He has no drug allergies and hasn't taken any antibiotics recently. So what would be the best empiric antibiotic regimen for this patient, keeping in mind everything we've discussed about fluoroquinolones?
That's a great case to illustrate the complexities of these decisions. We know that fluoroquinolones are often used for pneumonia, but in this case, we have to be very careful. Because of that aortic aneurysm, remember those FDA warnings?
Right. So even though a respiratory fluoroquinolone like levofloxacin or moxifloxacin might be effective against the bacteria causing his pneumonia, we should avoid them in this patient due to that increased risk of aortic rupture. What would be a safer choice?
A good alternative would be a combination of ceftriaxone and azithromycin. These are both broad-spectrum antibiotics that are effective against the most common causes of community-acquired pneumonia, and they don't carry the same risk of aortic complications.
So we're prioritizing safety over convenience in this case. And it's a good reminder that one size doesn't fit all in medicine. Each patient is unique. Okay, ready for case number 2?
Bring it on.
Okay, we have a 55-year-old woman admitted to the hospital with a urinary tract infection. Her urine culture grows Pseudomonas aeruginosa, and the medical team wants to start her on ciprofloxacin. What factors should we review before giving her the green light? What are those red flags that might make us think twice about using ciprofloxacin in this case?
This is another scenario that requires a careful balancing act. First and foremost, we need to confirm that the Pseudomonas aeruginosa from her urine culture is actually susceptible to ciprofloxacin. Resistance patterns can vary, and we don't want to start a drug that won't work.
Right. We need to make sure we're using the right weapon for the right enemy. What else should we check?
Given ciprofloxacin's potential to prolong the QT interval, we need to scrutinize her medication list for any other QT prolonging drugs, if she's taking any. Using ciprofloxacin could be risky.
And we definitely don't want to put her at risk of a dangerous heart rhythm problem. Anything else?
Absolutely. We also need to assess her kidney function. Remember, ciprofloxacin is primarily cleared by the kidneys, so if she has any kidney issues, we might need to adjust the dose or choose a different antibiotic.
Okay, so checking for sensitivity, QT prolonging drugs, and kidney function are all crucial steps before starting ciprofloxacin. It's like solving a puzzle, considering all the pieces before making a move. I think that's a good place to wrap up this part of our deep dive. We've covered a lot of ground, from the fascinating history of fluoroquinolones to their impressive mechanisms of action, and of course, their potential for serious side effects and drug interactions.
We've also seen how those tiny molecular tweaks can have a huge impact on a drug's activity, and how those variations allow us to target specific types of bacteria.
Exactly. And we've started to grapple with those ethical and clinical dilemmas that fluoroquinolones often present. But there's much more to explore. Join us in the next part of our deep dive as we delve further into the complexities of prescribing fluoroquinolones, including the crucial concept of antibiotic stewardship and the importance of shared decision-making with our patients.
It's remarkable how the evolution of fluoroquinolones reflects our growing understanding of how to fight bacteria. We started with a relatively simple molecule like nalidixic acid, effective but limited. Then, through scientific ingenuity and a touch of serendipity, we developed these highly targeted weapons capable of exploiting specific bacterial weaknesses.
It's like we've gone from fighting with sticks and stones to wielding lasers.
Yeah.
But as we've learned, even the most sophisticated weapons can have unintended consequences.
Exactly. And that's why approaching the use of fluoroquinolones with caution and respect is essential. They're not a magic bullet. And their prescription should always be guided by a thorough assessment of the individual patient, the specific infection, and a clear understanding of the potential risks and benefits.
It's a tightrope walk, isn't it? Balancing the need to use these powerful drugs when they're truly necessary, against the potential for harm.
Precisely. And that's where the concept of antibiotic stewardship comes into play. It's a multifaceted approach that focuses on optimizing antibiotic use to ensure they remain effective for as long as possible, while minimizing resistance and reducing the risk of those nasty side effects.
So it's not just about saying no to antibiotics altogether,
Yeah.
but using them wisely and responsibly.
Exactly. It's about choosing the right antibiotic for the right infection, at the right dose, for the right duration. And that means considering all those factors we've been discussing: the patient's medical history, allergies, potential drug interactions, and the specific characteristics of the bacteria causing the infection.
Sounds like a complex equation with a lot of variables.
It is, and it requires a collaborative effort. Doctors, pharmacists, nurses, and other healthcare professionals all need to work together to make sure patients get the best possible care.
And of course, educating patients and getting them involved is also crucial.
Absolutely. Patients need to understand why it's important to take antibiotics only when they're prescribed, to finish the entire course as directed, and to avoid sharing antibiotics with others, or saving them for later.
It's about debunking those myths and misconceptions that have fueled the antibiotic resistance crisis.
Exactly. We need to shift the mindset from seeing antibiotics as a quick fix for every sniffle to recognizing them as precious resources that need to be protected and conserved for future generations.
You know, all this talk about potential harm and the risk of resistance really raises some ethical questions. Given their downsides, how do we justify prescribing fluoroquinolones when safer alternatives might be available?
That's a tough question. And there's no easy answer. It's a decision that needs to be made on a case-by-case basis, weighing the potential benefits against the potential risks, and involving the patient in that decision-making process.
So open and honest communication with our patients is key. They need to know the potential downsides of fluoroquinolones to make informed choices about their treatment.
Absolutely, and that includes being upfront about the possibility of long-term, even irreversible side effects. We need to be transparent about the uncertainties and acknowledge that, even with the most careful prescribing, adverse events can still happen.
It's about respecting patients' autonomy and empowering them to make choices that align with their own values and preferences.
Precisely. And that might mean opting for a less effective but safer antibiotic in some cases, or accepting a slightly higher risk of side effects if the potential benefits are significant.
It's about finding that sweet spot, that optimal balance between maximizing the benefits of treatment and minimizing the potential for harm. And that balance will look different for each patient, won't it?
Exactly. There's no one-size-fits-all approach. It's about tailoring the treatment plan to the individual, considering their unique circumstances and priorities.
And that takes more than just knowing the science. It requires the art of patient care, empathy, compassion, and building trust.
You're right. It's about seeing the whole person, not just a set of symptoms or a disease.
It's about recognizing that every patient has a story, hopes, fears, and values that shape their healthcare decisions.
And we, as healthcare providers, need to honor those stories, acknowledge those fears, and work together with our patients to find the best path forward.
It's a partnership, a journey we navigate together. where both patient and provider play active roles in decision-making.
Precisely. And while that journey may involve difficult choices and trade-offs, by approaching it with compassion, transparency, and a commitment to shared decision-making, we can create a healthcare experience that's both effective and empowering for the patient.
That's a powerful statement. It's about moving beyond that traditional hierarchical doctor-patient relationship and fostering a more collaborative and patient-centered approach to healthcare. Speaking of which, remember that first case we discussed? The 70-year-old man with pneumonia and the aortic aneurysm. Let's say his pneumonia doesn't improve on ceftriaxone and azithromycin, and the only other antibiotic option is a fluoroquinolone. What do we do then? Do we prioritize his immediate need for a potentially life-saving antibiotic, even if it means accepting a higher risk of aortic complications?
That's the kind of ethical dilemma that clinicians grapple with all the time, especially in complex cases. There's no easy answer. And the best course of action will depend on a variety of factors, including the severity of the pneumonia, the patient's overall health and life expectancy, and most importantly, his own wishes and values.
So it boils down to that shared decision-making again. We need to have an open and honest conversation with the patient, explaining the risks and benefits of each option, and helping him make a choice that aligns with his goals of care.
Exactly. And it's important to remember that there's no right or wrong answer. It's about respecting the patient's autonomy and supporting him in making the best decision for his individual circumstances.
That's a great point. It's a reminder that medicine is not just about applying scientific knowledge, but also about navigating those gray areas, those situations where there's no clear-cut answer.
And that's what makes it both challenging and rewarding. It's about using our knowledge and skills to help patients navigate these complex decisions and find the best path forward, even when the path is uncertain.
Okay, let's switch gears for a moment and talk about something that really stood out to me in those articles we reviewed. The importance of understanding the specific resistance patterns of the bacteria we're dealing with. It's not enough to just know that a particular bacteria is susceptible to fluoroquinolones in general, right?
You're absolutely right. We can't just assume that any fluoroquinolone will be effective against any given strain of bacteria. We need to check the susceptibility results from the lab to make sure we're choosing a drug that will actually work.
Right, because resistance can vary widely, even within the same species of bacteria. And we know that overuse and misuse of fluoroquinolones have contributed to the development of resistance, making these drugs less effective over time.
Exactly. It's a vicious cycle. The more we use these drugs, the more likely we are to face resistance, which then limits our options down the road.
And that brings us right back to antibiotic stewardship. We need to use these precious resources wisely and responsibly if we want to keep them in our arsenal.
I couldn't agree more. We have to think about more than just the patient in front of us. It's about the collective good and the long-term health of our communities.
It's about recognizing that the decisions we make today have ripple effects that can impact the health of future generations.
Precisely. And that's a responsibility we all share. Doctors, pharmacists, nurses, patients, policymakers, and the public all have a role to play in protecting these vital medications.
Well said. We've covered a lot of ground today, from the nitty-gritty of fluoroquinolone pharmacology to the broader ethical and societal implications of their use. It can feel a bit overwhelming, can't it? All this information about mechanisms, resistance, side effects, and interactions.
It's a lot to process, for sure. Don't be afraid to take your time, ask questions, and do your own research to solidify your understanding.
And remember, the key takeaway is not to memorize every detail, but to grasp those big picture concepts. Understanding the potential benefits and risks of fluoroquinolones, the importance of judicious prescribing and antibiotic stewardship, and those ethical considerations that come into play when making treatment decisions.
And most importantly, remember that you have a voice in your healthcare decisions. Don't hesitate to ask questions, express your concerns, and advocate for your own well-being.
Great advice. Okay, before we wrap up this part of our deep dive, we have one final case study. This one really brings all these concepts together, ready to dive back in.
Absolutely. Let's put all this knowledge to the test.
Here we go. A 35-year-old woman comes to the clinic with classic UTI symptoms: painful urination, frequent urges, and lower abdominal discomfort. She's otherwise healthy and has no history of allergies. The urine dipstick test is positive for those telltale signs of a bacterial infection.
Sounds like a straightforward, uncomplicated UTI. What's the next step? Do we know which bacteria is causing the infection?
A urine culture was sent to the lab, and the results are pending. But the doctor wants to start empiric antibiotic treatment right away to relieve her symptoms and prevent things from getting worse.
That's a reasonable approach, especially considering how uncomfortable she must be. So the question is, which antibiotic to choose?
The doctor's considering two options, nitrofurantoin and ciprofloxacin. Both are frequently used for UTIs, but they have different mechanisms of action, spectrums of activity, and potential for side effects.
That's right. Nitrofurantoin is generally the preferred first-line choice for uncomplicated UTIs, especially in younger women who are otherwise healthy. It's usually well tolerated and has a low risk of causing resistance.
And because it's specific to the urinary tract, it doesn't disrupt the balance of bacteria in other parts of the body, which can be an issue with broader spectrum antibiotics like ciprofloxacin.
You're right. But nitrofurantoin does have its limitations. It doesn't achieve therapeutic levels in the kidneys or bloodstream, so it's not effective for more complicated UTIs that involve those organs.
And I think it can also cause some side effects, like nausea, vomiting, and in rare cases, lung problems.
Those side effects are usually mild and tend to resolve once the medication is stopped. Now, what about ciprofloxacin? It's a broader spectrum antibiotic, so it covers a wider range of bacteria, including some that might be resistant to nitrofurantoin.
So it might be a good option if we're worried about a more resistant strain, or if the patient doesn't respond to nitrofurantoin.
Exactly. But we have to remember all those potential risks and side effects we've discussed. Tendinitis, tendon rupture, aortic aneurysm, blood sugar disturbances, and those pesky drug interactions.
And of course, the risk of fueling antibiotic resistance is always a concern with broader spectrum antibiotics.
Absolutely. So we're back to that balancing act, weighing the potential benefits against the potential risks in this case. Considering it's an uncomplicated UTI, in a young, healthy woman with no allergies, nitrofurantoin seems like the safer and more appropriate choice for empiric treatment.
I agree. It's consistent with those core principles of antibiotic stewardship.
Yeah.
Choosing the narrowest spectrum antibiotic that's likely to be effective, and minimizing the risk of resistance and adverse effects.
Precisely. And if the culture comes back showing a resistant strain, or if the patient doesn't respond to nitrofurantoin, we can always switch to ciprofloxacin or another suitable antibiotic at that point.
It's a stepwise approach, starting with the safest and most appropriate option, and only escalating if needed.
Right. And throughout the process, we keep the patient informed and involved in the decision-making.
It's all about empowering her to understand her options, weigh the risks and benefits, and make choices that align with her preferences.
I couldn't agree more. It's about building a collaborative relationship based on trust, respect, and shared decision-making.
Now, before we jump into part 3 of our deep dive, I have a quick question for our listeners. Let's say this patient's urine culture comes back showing E. coli, a common culprit in UTIs. And to our surprise, it's resistant to nitrofurantoin, but susceptible to ciprofloxacin. What are your thoughts? Would you feel comfortable prescribing ciprofloxacin in this case? Knowing what we've discussed about its potential risks, take a moment to ponder that. We'll pick up this thread and delve into those final case study scenarios in part 3.
Yeah, that is a tough one. It really makes you think about the whole picture, doesn't it?
It does. You know, we've talked about all the potential risks of ciprofloxacin, but at the same time, this is a real person with a real infection that needs to be treated. So how do we balance those two things?
Right. It's all about finding that balance between being cautious and being effective. And it's not always easy. So in this case where the E. coli is resistant to nitrofurantoin, but susceptible to ciprofloxacin, we have to carefully weigh the risks and benefits of using ciprofloxacin.
So what are some of the things we should be thinking about?
Well, first of all, we need to make sure that ciprofloxacin is actually appropriate for this patient. That means checking for any contraindications like allergies or drug interactions.
Right, because we know that ciprofloxacin can interact with a lot of different medications.
Exactly. And we also need to consider her overall health status. Does she have any other medical conditions that might make her more susceptible to side effects? For example, does she have any kidney problems? Because ciprofloxacin can be hard on the kidneys.
Those are all really important points. And I think it's also important to remember that ciprofloxacin is a pretty powerful antibiotic. So we want to make sure we're only using it when it's truly necessary.
Absolutely. We don't want to overuse these drugs and contribute to the problem of antibiotic resistance.
So how do we approach that conversation with the patient?
Well, I think it's really important to be honest and upfront with her about the risks and benefits of ciprofloxacin. We need to explain that it's an effective antibiotic, but that it also has the potential to cause some serious side effects.
And we need to make sure she understands those side effects so she can make an informed decision about her treatment.
Right. It's all about shared decision-making. We need to work together with the patient to come up with a treatment plan that she's comfortable with
And if she decides that she doesn't want to take ciprofloxacin, are there any other options?
There might be. Depending on the specific circumstances, we might consider a different antibiotic, or we might try a non-antibiotic approach.
It's really important to have those conversations with patients and to
Right.
explore all the available options.
Absolutely. It's all about providing personalized care. That's tailored to the individual patient's needs and preferences.
Well, I think this case really highlights the complexities of antibiotic prescribing and the importance of careful consideration and shared decision-making.
I agree. It's not always a straightforward process, but by taking the time to gather all the necessary information and to have those open and honest conversations with our patients, we can make sure we're providing the best possible care.
And that's what it's all about at the end of the day, isn't it?
It sure is.
Well, I think this brings us to the end of our deep dive into the world of fluoroquinolones. We've covered a lot of ground today, from their history and mechanisms of action to their clinical uses, side effects, and drug interactions. We've also talked about the importance of judicious prescribing and the need to address the growing problem of antibiotic resistance.
And we've emphasized the crucial role of communication and shared decision-making in ensuring that these powerful drugs are used wisely and responsibly.
Thank you to our listeners for joining us on this journey. We hope you found it informative and thought-provoking, and we encourage you to continue exploring the fascinating world of infectious diseases. Until next time, stay curious and stay healthy.